So over the next 10 minutes, I'll review what we know about perianal Crohn's disease, and perhaps more so what we don't know about perianal Crohn's disease management. These are my disclosures. I'll go over what is involved in the perianal area in Crohn's disease, and then review the management principles, surgical and medical, for abscess and fistula attributed to Crohn's, and then maybe review the new developments in therapies there. The multiple issues that Crohn's disease can involve the perianal area include skin tags, ulcers or fissures, and then the trio of having fistulas that are often associated with abscesses and more so than not associated with rectal anal strictures. We shouldn't forget about the risk of neoplasia attributed to chronic Crohn's disease inflammation in the perianal area, but this will not be the focus on my 10-minute talk today. A bit about skin tags in Crohn's disease. These are often confused with hemorrhoids, and they should not be. They may not be related to the presence of rectal Crohn's disease, and we think the pathophysiology here is the inflammatory cells essentially obstructing the lymphatic drainage of that area and leaving the folds to swell. Now, certainly the perianal skin tags could improve with treatment. They might shrink, but I would never promise a patient that these skin tags would disappear. And the last thing that I would want for those patients is to have it touched by a surgeon, no matter how experienced a surgeon is, because we have a huge risk of post-procedure complications, including non-healing, chronic infections, pain, and strictures. And with those complications is a high risk of more extensive resection. Perianal ulcers and fissures, these should be considered Crohn's ulcers, and the idea is that we could treat them the same way we treat the Crohn's inflammation. The location could be variable, midline, or lateral. We should consider alternative diagnoses, which may not be common, but in a patient who's in deep remission, constipation or trauma-induced fissures should be considered. Management is mainly treating underlying Crohn's and keeping the area with the least degree of irritation. Let's move on to fistulas. If you're crazy about numbers, I put a bunch in there for you, but we know about 20 to 50% of all Crohn's patients will get a fistula at some point in time during their disease course, and 10% will have it at presentation. 5% will have perianal disease without having luminal disease. The luminal disease may show up later. And there's no consistent association between the presence of a perianal fistula and rectal disease. Having rectal disease makes it more complicated to manage, but there is no one-to-one association with the presence of rectal disease. And as we all know, the fistula itself and its complications, namely an abscess, could actually leave patients with very low quality of life, and that's attributed to pain, the cost of their care, and the need for multiple surgical procedures and biologic therapies. In fact, before the biologic therapies were available with complex fistulas, more than 2/3 of patients required fecal diversion. So it used to be a very common occurrence. It's less common now, and that's something that we attribute to the biologics. A bit about the pathophysiology. It's quite interesting to look at this hypothesis. We hypothesize that the inflammation itself perhaps forces the epithelial cells or the destined epithelial cells to be a little bit on the transitional cell type side, so mesenchymal cell instead of being an epithelial cell. And these mesenchymal cell types could act more like myofibroblasts, which have significant capacity to produce proteases. They destroy the matrix in their local area, and couple that with the pressure within the rectum, perhaps the formation of an abscess, which is also destructive to the tissue. This is how you create a fistula tract. The types of these fistulae, there are different classification systems. I'm not going to focus on those, but we can simplify it and say you can have a very simple fistula which does not go higher up beyond the anorectal transitional zone, and it doesn't involve much of the sphincter. However, these simple fistulas are the exception. So less than 10% of all fistulas are simple and do not involve the perianal sphincter in some capacity. So the majority will be on the complex side. So simple fistulae, low, do not involve the sphincter, generally good prognosis. They have usually one opening. Complex fistulas, they're higher. They have a difficult and tortuous course around the sphincters, and they could have multiple openings and different branches. And these are the fistulas that are complicated. The symptoms and signs. A fistula itself may leave patients with drainage. So local hygiene, soiling is the major issue. Maybe itching because of the skin irritation. But for the abscess, the pain is the hallmark. And this is perhaps one of the most painful complications any Crohn's patient could have. Fever is uncommon, and local tenderness will be present with some fluctuation if the abscess is superficial enough. However, if my Crohn's patient is in the ER with pelvic pain or anal pain, and there's nothing externally, I would still insist on imaging because we could miss an abscess there. The differential diagnosis, fortunately, is not common. I wouldn't delve into that in detail in the interest of time. To diagnose it, good history and exam. Imaging would help to define the anatomy of the fistula and also to delineate the presence or absence of an abscess. However, in a patient who has a clear abscess, waiting for imaging is not a good idea. You want to get that patient to have less pain by draining the abscess sooner than later. CT, fistulography do not have a significant role here. The go-to study seems to be the MRI of the pelvis with IV contrast. It should be easy and fast to get. In our center, just ask your radiologist time and again, and they should be able to provide the service at 3 a.m. It's a quick study. This is not interrography, and it's not an MRI of the pelvis per se. It's really, sorry, of the abdomen per se. It's a simple, limited MRI of the pelvis. There's a growing role for intra-anal ultrasound, and this modality can be helpful, and Dr. Schwartz has reported his experience there in multiple studies. It could be technically difficult to do intra-anal ultrasounds. It has limitations when the fistula course is deeper in the pelvis, and certainly if you have an associated stricture, you cannot get that ultrasound probe in. So obviously a lot of limitations there. The principles of managing perianal abscess, I'll start with an abscess first, is simple. We need to manage the pain, oftentimes with opiates. We need to drain the abscess. This is a driver for that patient's pain, and drainage sooner than later is a good idea. We need to treat the infection or the sepsis, and this could be with a short course of intravenous antibiotics until the drainage is done. If a patient has mild pain, not requiring IV narcotics, we can try to use oral antibiotics. The trick here is to extend the course of antibiotics. And then if there's a stricture, this should be addressed. And then treating the underlying Crohn's disease that drove the fistula in the first place is a focus. And then once you treat the inflammation, you drain the pus, you're looking at Crohn's disease management, then you start looking at how do you close that fistula tract. I put the slide here not to go through the very recent published guidelines, the consensus-based guidelines called the Toronto Consensus, published last month. But I put this up to point out that the quality of the evidence for these recommendations ranges from low to very low. So what we have is really mostly consensus-based guideline. It is a practical guideline, nevertheless, and that's probably all that we have today. Once we drain the abscess, the guidelines suggest the combination or monotherapy with anti-TNF and immune modulator, monotherapy with the anti-TNF agent, and continuing therapy without stoppage in patients who respond. In the interest of time, I summarize what we know about the medical therapy so far. We know that the combination of two medications, so antibiotics and thiopurines, or antibiotics and anti-TNF agents, namely adalimumab and infliximab, is better than monotherapy. In addition, we have recent data that a better anti-TNF trough is associated with better success with fistula closure. Thiopurine on its own may not be quite successful in the long run. Brian Fagan has given us some data. This is a sub-study from the key new biologic clinical trials with vedolizumab and with ustekinumab that show some benefit, but certainly this was not the quality of data that we have for infliximab, for example. Now, intravenous cyclosporine, interestingly not with oral cyclosporine, but intravenous cyclosporine can be an option in your difficult patient. Tacrolimus has been reported to have benefit there in your more difficult patient. And thalidomide, which is a challenge to use, but nevertheless has had some benefit there. In terms of the surgical management, we'll address that more during the panel. We need our surgeons to drain the pus, and that's the quickest way to reduce the pain. And we need our experienced surgeon to help us perhaps identify the anatomy of that fistula. As long as the fistula is there, as you are trying to heal the Crohn's inflammation, if that fistula gets plugged from both ends, this is where your abscess recurrence could happen. And perhaps the role of what we now use, namely the non-cutting ceton drain, is to keep that fistula open and prevent another abscess from happening as you treat the underlying Crohn's disease. So we tell our patients we're going to drain the abscess, get a definition of your fistula tract from imaging, get an examiner anesthesia, whether it's early or late after the drainage, and then place a ceton drain and start you on the biologic with or without an immune modulator, and expect maybe some recurrences in the first few months. There's controversy about how long do you keep a ceton drain, and when do you take it out, and we can address this in the panel discussion. Once you have your ceton drain, your medical therapy is ongoing, then you have options, your surgeon has options to look at closing up that fistula. This is the fistula that continues to drain in a patient that has deep remission, hopefully, for their luminal Crohn's disease. And for those patients who are more challenging, fecal diversion and abdominal perineal resection ends up being the case. And fortunately, it's a minority of patients. So long-term, we think that's under 30%. I listed here the outcomes of these procedures. I think you have to look at the heterogeneity of these studies. The patient criteria were not the same. For example, to say if fistulotomy is 100% successful, that's really for very simple, very limited fistulas, and that's the exception, not the rule for the majority. Oftentimes, you need to redo these procedures, like a fistula plug or a ligation of the fistula tract. Fecal diversion, unfortunately, again, a reality for patients, hopefully under 30% of all of our patients, and it's indicated if you have a tight stricture or chronic fecal incontinence. It could take months and months and months to see the maximum improvement in the perianal disease after fecal diversion. And nevertheless, even with that improvement, there is a high chance that disease recurrence will be there if you reconnect the patient. So it doesn't look good for patients who get diverted that they will be successfully reconnected. My last slide will look at novel therapies. We've had some reports about local anti-TNF injections, adalimumab and infliximab. These studies seem promising with good results. However, again, the studies themselves are quite variable. In some of the studies, there was ongoing systemic anti-TNF therapy. And is the benefit really the local injection versus a systemic therapy? I think that's a question mark. Stem cell therapy, which is very promising with ongoing clinical trials now. You take the patient's own stem cells from stimulated bone marrow or from fat tissue, and now it's an industry to collect stem cells from liposuction procedures. So I'm going to save my fat when I do it. It seems to be promising. However, there was a high placebo response rate, and it maybe emphasizes the role of good local surgical cleanup and management of a fistula tract. Some ongoing experience with oral adsorptive carbon. It seemed to be mixed results. And then interesting data from hyperbaric oxygen use after numerous sessions. So in summary, this can be a very complicated issue for at least 25–50% of our patients. We need a multidisciplinary team with experienced gastroenterologists and surgeons to handle this. A lot of unanswered questions: combination therapy, early or not early combination therapy, top-down therapy, when to use MRI studies, how can you help with the prognosis with MRIs, and then when to de-escalate therapy if you close up a fistula surgically. and then more promising new therapies, including stem cells. Thank you.